So I'll be presenting today on retinal vasculitis. It's a basic topic of uveitis. So what is retinal vasculitis? It is inflammation and necrosis of the retinal blood vessels. This is the basic pathology that we are dealing with. Again, inflammation and necrosis of retinal blood vessels. What are the characteristics? It is the characteristics are perivascular sheathing, which is seen at white areas around the vessels. You can see in any vasculitis case. Vascular leakage. If you do angiography, you can see leakage along the vessels, and vascular occlusions where the vessels are occluded, which causes hemorrhages, capillary dropouts, etc. So, so retinal vasculitis is basically inflammation and necrosis of the retinal blood vessels. It is characterized by the triad of perivascular sheathing, vascular leakage, and vascular occlusion. One has to understand that vasculitis is not limited to retinal circulation. It can also have its effect as conjunctivitis, episcleritis, scleritis, peripheral, peripheral ulcerative keratitis, proptosis, orbitis, and uveitis. So all these disease manifestations can have element of vasculitis. The clinical features: gradual or sudden painless loss of vision. It can happen either. If you have a patient with vitreous hemorrhage, if they can have a sudden painless loss of vision. If you have a patient with a macular edema secondary to retinal vasculitis, it can have gradual painless loss of vision. So sudden loss of vision, why? Because if there is a vitreous hemorrhage, sudden amount of vitreous hemorrhage cause sudden loss of vision. Gradual painless of vision, why? Because if there is a macular edema which develops, which causes gradual painless loss of vision. So vitreous, so basically retinal vasculitis will come as a cause of vitreous hemorrhage. So if you are asked in examination what are the causes of sudden loss of vision, you might tell it is a vitreous hemorrhage is a cause of sudden loss of vision, and then they may ask you what are the causes of vitreous hemorrhage. Among the various causes like diabetic retinopathy, branch retinal vascular occlusion, breakthrough hemorrhage in AMD. Vasculitis is also an important cause of vitreous hemorrhage, especially in Indian scenario in young adult males. Floaters can be seen because you have.
Dr. Rupak, one second, just 1 second. I'll ask a question to the postgraduates. We discussed this yesterday, exactly what Sir mentioned, Dr. Rupak mentioned. I had given the name of one particular disease in the Indian population. I want you all to type out that disease name as a common cause of vitreous hemorrhage, the disease of uveitis. We'll go ahead with your question. Go ahead, Rupak. Thank you so much.
So the other clinical features could be a scotoma, photopsias, because we know why photopsia, because retinal vasculitis can give rise to fibrovascular proliferations, which can give which can start pulling on the retina and give you photopsia. Similarly, macular edema can give rise to metamorphopsia, and retinal vasculitis can also have color vision alterations because of its effect on the cone photoreceptors. So what are the causes? So there is a elaborate cause of retinal vasculitis. I'll just go through the names. They are sarcoidosis, rheumatoid arthritis, SLE, giant cell arthritis, PAN, vaginous granulomatosis, seronegative arthropathies, Takayasu disease, ulcerative colitis, Crohn's disease. So this is an important slide in the sense if for exams if you have to write what are the causes of retinal vasculitis, you should at least write 5 or 6 out of this: ulcerative colitis, Crohn's disease, antiphospholipid antibody, Sjogren's syndrome, and retinal S antigen associated vasculitis. So this is an important slide for exam purpose.
Dr. Rupak, one question here. I have seen most of these cases in my practice. Vagus dermatitis is also I think I have seen. But if I ask you in a routine medical college OPD, can we go back to that slide, please? Yeah, yeah. Now, in a routine medical college OPD, out of these which would you think is the commonest or reference from the medicine department or reference from the rheumatology department? Which do you think are the commonest in these?
I think sarcoidosis would be the commonest out of these.
Right. So, and they will normally come from which department, or where would you send the reference to?
The chest department.
Chest department, correct. So I think the postgraduates need to know that sarcoidosis we are thinking of in your mind. We think it's a possible diagnosis. Somebody mentions it, or somebody says patient has sarcoidosis with floaters or with some visual distortion. You know the chance of vascular. This correlation should be there systemically also. I'm sorry. Can we go ahead, please?
Again,
Before that, I must. Sorry. Intas people, please note the names Dr. Naina, Dr. Priyanka, and Dr. Afifa Azam. These are the first three fastest finger first. Please note. Can Dr. Priyanka, if I remember, is correctly from Pune somewhere. DY Patil, Dr. Naina, and Dr. Afifa. I think, if I'm not mistaken, can the three of you, Diana, Priyanka, and Dr. Afifa, kindly put which medical college and which city you're from? We'll ask the Intaspit to contact you all. Thank you so much. We'll go to the top.
so again, coming to the infectious causes, there are various infectious causes like tuberculosis, which is very common in Indian scenario, syphilis, Lyme disease, leptospirosis, Whipple's disease, Bartonella, bacterial endophthalmitis, and brucellosis. Again, important slide. You need not know all. You need not remember all the names. At least three out of this, if you can remember and write down, it will be okay. Parasitic causes could be toxoplasma, toxocariasis, fungal candidiasis, protozoan amoebiasis. Viral causes, these are very important. Viral are important causes of retinal vasculitis. Herpes simplex virus, herpes zoster virus, cytomegalovirus, all these three can cause retinal vasculitis. Hepatitis, mononucleosis, chickenpox, and West Nile virus. So again, very important is toxoplasmosis here, which is a rare cause of retinal vasculitis, and viral causes herpes simplex, herpes zoster, and cytomegalovirus. There are zillion of other causes like the pars planitis, intermediate uveitis, prostate bronchitis, Irvan, Eels disease, neurological disorders like multiple sclerosis, and etc. I'll not go into the details of this list. So next, whenever you are starting with the diagnosis of a case of retinal vasculitis, you have to understand that a specific pattern of vascular involvement is noted. So in cases of vaginal granulomatosis and microscopic polyangiitis, only the small vessels are involved. Whereas in a polyarteritis nodosa and a Kawasaki disease, the middle-sized vessels are involved. In a large vessel, are involved in giant cell arteritis and Takayasu arteritis, where the capillaries are involved in the Gooch-Pasteur syndrome and Henoch-Schönlein and purpura. So whenever you are dealing with a case of retinal vasculitis, if you see the patient clinically, if you see the patient's angiography, try to identify which order of vessels are involved. What is the pathology? So there is development of autoreactive T and B lymphocytes that damage target organs. What are the target organs? They are vascular endothelium, vessel wall, intracytoplasmic granules, intranuclear proteins of nucleated cells. Most of the cases have involvement of the veins, that is known as phlebitis, and perivasculitis in others. So what happens ultimately is necrosis of the vascular endothelium and occlusion of the vessels. Now this is an important slide. As I told you, most of the cases have retinal phlebitis. Phlebitis means involvement of the veins. So Behçet's disease, sarcoidosis, tuberculosis, multiple sclerosis, Eels disease, pars planitis, they all primarily affect the retinal veins. On the other hand, polyarteritis nodosa, SLE, and viral retinitis are the causes where primarily the arteries are involved. So this is important slide in the sense you have to distinguish whenever you see a case of retinal vasculitis, you have to make two quick decision making points. One is whether it is a large vessel vasculitis, medium vessel vasculitis, or a small vessel vasculitis. And second, whether it is a phlebitis, I mean it is involving primarily the veins or it is involving primarily the arteries. So what are the pathological retinal changes? So one is vascular sheathing. What is that? That is that is caused by inflammatory cells around the vessels, vascular endothelial factors, and cell adhesion molecules, and diabetes causes migration of inflammatory cells to the sides of the vessels. Vascular occlusion causes nerve layer infarcts, which we know as cotton wool spots. Now we have occlusive retinopathy because of vascular occlusion. So what happens in a case of retinal vasculitis? There is occlusion of the retinal vessels. Now the retinal vessels are important source of blood supply. So if the blood supply is occluded, the capillary dropout occurs. The capillary dropout means there is ischemia. So ischemia gives rise to neovascularization, and this neovascularization causes bleeding and vitreous hemorrhage. So you have to understand this pathology very importantly. So occlusive retinopathy is basically the cause of vitreous hemorrhage. What happens there is occlusion of the retinal vessels causing to capillary dropout, causing retinal ischemia. Whenever there is ischemia, the body sends signal that it needs more oxygen. So how that oxygen is possible? That is possible by formation of new blood vessels. So there is formation of new vessels. Now the new vessels are very thin and fragile. So they are very prone to bleed. This bleeding causes vascular vitreous hemorrhage, and as time progresses, there is fibrosis and traction around these new vessels, which causes a tractional retinal detachment. These are the end stage sequelae of retinal vasculitis. So retinal hemorrhages also can be seen, and vascular architectural alterations like arterial venular anastomosis and crossing of vessels over the horizontal raphe. So now we come to the important part. We have gone through the causes of retinal vasculitis. We have gone through the pathology of retinal vasculitis. We have gone through the symptoms of retinal vasculitis and clinical features we have done. Now, when the patient comes to you, what are the important medical history that you should take to rule out various causes of retinal vasculitis? So, if a patient has orogenital ulcers, arthalgia, skin rash, you suspect of Behçet's disease. You have to specifically take history of this thing. You have to ask patient specific questions. If there is a history of weight loss, cough, there are skin lesions, and hilar lymphadenopathy, you know you are dealing with a case of sarcoidosis. Night fever, sweat, cough with expectorations, you are dealing with tuberculosis. Joint pains, backache, seronegative arthropathy. Neurological symptoms, if the patients have, you might be dealing with a case of multiple sclerosis. So these are
Uh,
the
yeah, Dr. Rupa, can I just to make it a little bit more different now? Can I ask you? These are the systemic features of this particular disease. In Behçet's disease, what is the typical clinical finding we will find in the patient in the eye?
typical finding is, I'll come to that.
Okay, okay. Sorry. Go ahead.
So if the patient has various thromboembolic episodes, you can think of antiphospholipid antibody syndrome, contact with pets, toxoplasmosis, sexual habits important for HIV and syphilis, exposure to animals like sheep, cattle, and swine for brucellosis. Now coming to the basic investigation, what are the basic? Whenever you see a patient of retinal vasculitis, you are going to order some investigations. They are the investigations that must be included in the battery are a complete blood count with a basic cell count, ESR, a basic coagulation profile, a TPHA test, a MANFU test, serum ACE inhibitor assay, rheumatoid factor, ANA factor, HLA
I
typing, HLA typing if available, HLA B51 for Behçet's disease, and HLA DR3 for SLE,
uh,
ANCA, PIANCA, anti-TS DNA, complement levels, and lumbar puncture to rule out neurological everything. So again, this list is very important. This list is very important for exam long question. This is must. These are the basic tests that one must do in order to look for to do a workup of a case of retinal vasculitis.
Dr. Manish, can you mute your Dr. Manish? Can you mute your mic, please? Thank you. Yeah, let's go ahead.
Yeah. Now coming to the infective causes, the for cases like tuberculosis, you need Mantoux test, a quantiferon gold test, a VDRL test for syphilis, antibody titers for Lyme and toxoplasmosis, ELISA for HIV and Lyme disease, and vitreous biopsy with PCR. You can take PCR either from the anterior chamber or from the vitreous for HSV, CMV, Toxopada, Leptospira. Some ancillary imaging investigations might be needed, like fundus fluorescein angiography. This is done to look for new vessels, whether there is formation of new vessels. Chest X-ray to look for hilar lymphadenopathy. Sinus X-ray for vagus granulomatosis. X-ray sacroiliac joint for seronegative arthropathies. MRI for multiple sclerosis. HRCT scan for tuberculosis, and OCT for to detect any macular edema if present. So, what are the principles of treatment? The main goals of therapy is to decrease the intraocular inflammation, to facilitate visual recovery, and to prevent long-term vision loss. So, what are the mainstay of treatment of vasculitis is systemic steroids. So, what is it? Oral prednisolone, 1 milligram per kg of body weight in tapering dose, and if there is an involvement of the optic disc or the threatening of the macula by any choroiditis lesions, you can think of giving IV high dose pulse methyl prednisolone. At times, posterior subtenon depot injection of triamcinolone acetonide can also be tried. Topical steroid with cycloplegics for coexisting iridocyclitis. So the mainstay of treatment is oral prednisolone. Sometimes, if you are faced with a vision-threatening situation, you can think of giving IV high-dose pulse methyl prednisolone. But for all routine purposes, oral prednisolone suffices. In cases associated with intermediate uveitis, you can think of giving posterior subtenon depot injections. And with associated anterior uveitis, you have to give topical steroids with cycloplegics for coexisting iridocyclitis.
I'll just, Dr. Rupak, just to make it a little bit more interesting, different, can we go back, please? Can we go back one slide, please? Yeah, excellent. So I'll just to break the discussion over here a little bit. So you're telling me that if I've diagnosed a patient of uveitis and I should do a few blood tests to see. That means if a patient has come to me, some little small dots they were seeing, and they were seeing vision is hazy for the last 1 or 2 weeks, getting worse slowly. Other eye looks normal. Young patient, I see inside. I see the vitreous little bit hazy. I see some inflammation of some blood vessels, some small inflammation around the blood vessels. They look a little whitish. Little bit of small hemorrhages I see here and there. Very few corneal spots, not too many. Then at starting also have a history about system. Do you have fever? Do you have cough? Do you have rash? Any history of exposure, sexual exposure, any pet contact? I ask all those questions. I write down on my prescription maybe just a basic hemoglobin T CSF, fasting blood sugar, ask for an LFT because I want to see if I give steroids for a long time, I want to shift to uh, others, other medications, Azuran and all later on. I want to get that out of the way. Do a chest X-ray. Um, do a stool for occult blood to see if there's any leaking, any stool in the any occult blood in the stool. Do a MAN2
इसमें
test to
वही
check your
चलने लगा है।
So I do all these.
वहाँ पे चलिए रहा था, तो यहाँ क्यों आने लगा मैसेज?
Yeah. So can we have somebody's with Mr. Dr. Ratan Srivastav? Can you mute your mic, please, Ratanji? Ratan Srivastav, please mute your mic.
मेरा आवाज है लेकिन
Mr. Ratan Srivastav, Dr. Ratan Srivastav, please mute your mic. Thank you very much. So, okay, we have a question, Rupak. It's a nice question. Venkat, I will use the question. I will not answer it right now. We'll do this because it goes off. Rupak, listen to the question. Dr. Venkat from, I think, Vizag says, Sir, in case of vision-threatening vasculitis, should we first rule out infectious cause before giving steroid? And if so, what all investigations should be done to rule out common infections? So basically, he says that he does not know what the diagnosis is. What investigation should he do? And should he do those before giving oral steroids? We leave that question for now. I'm sure Rupak will come to that. But I'll just continue what I was saying. Can we have next slide, please, Rupak, please? Yeah. Now, this is a thumb rule that all of us follow, 1 milligram per kg per day. What sometimes happens is you routinely give 60 milligrams. Adult big person gives 60 milligrams. Now you must understand sometimes we have very big human beings who are really 85, 90 kgs. And it's possibly that they may not respond to 60. That will be nearly a two-third dose only for them. So involve your physician, tell them you want to give a higher dose, and maybe give a higher dose than 60 if you think they're really, really fat or big built or well built people, huge guys, 6'2", some big built guy, or somebody really overweight. Sometimes 50 or 40 milligram. I've seen prescriptions starting with only 40. That itself will never do 1 milligram per kg. I think is the minimum dose one should use. But 60 is the thumb rule of use, which I don't think is correct. Dr. Rupak, do you agree with me on that?
Yeah, correct. I also agree with that.
Yeah. Now, there is one more thing here. The subtenon depot, I think a lot of uveitis people are very fond of this. Like exactly, you're not sure if a diagnosis, you are getting some tests done, you want to immediately attack the patient with some treatment. So subtenon steroid depot is quite a good idea. I don't practice much uveitis, but I know all of you do, or Dr. Rupak does. The one finger thing that they follow is the moment they see that the disc is involved and the macula is threatened, let's say with a choroiditis or one of those vasculitis things, they go for IVMP. When there is a fovea threatening lesion or the disc involved lesion, these are patients for IVMP. This is a very generalized guideline that I've given. Dr. Rupa, could you advise with that guideline that I've given?
Yeah, correct. That is what. If the disc is involved or the fovea is involved with some sort of a choroiditis lesion or a disc is involved with the disc edema, then you go for IVMP.
Because these are patients you can't wait, by the steroids act 3, 4, 5, 7 days. You may lose that very quick first 2 days gap you might lose. Dr. Venkat's question, should we rule out infectious causes first? I think yes. Dr. Venkat, Dr. Rupak will agree with me that we must rule out infectious causes first. And like he said, from your history to your findings, you have to have a differential diagnosis. And so if you ask what all the investigations should be done to rule out common infections, you would of course have tuberculosis very high on your thing. You would have sarcoidosis very high on your like Dr. Rupak said. Sarcoidosis is not an infective cause, but any other. Dr. Rupak, to make it easier for me, would you like to answer that question? I think I made a mistake there.
No, I think his question is very good and pertinent. We mainly need to rule out infectious causes like tuberculosis and the causes like viral diseases like HSV infection or HSV and HCV, which are causes which can give rise to retinal vasculitis also. So these are the things that we should rule out. But basically by taking a thorough medical history and doing a clinical examinations, most of the times you are able to arrive at a diagnosis whether you are dealing with the infectious cause or a non-infectious cause. So that will make your job easy. Then obviously you have battery of investigations to rule out again a viral vasculitis, again a toxoplasmosis, against the tuberculosis. These are the common infections in our settings.
So to list it
Question.
sorry.
I just wanted to ask a question to Dr. Rupak. In non-infectious uveitis, you've given 3 doses of pulse steroids. What is your follow-up regime? Do you then switch over to oral steroids, and how do you decide the dosage? When do you again re-evaluate this patient?
I usually give 3 pulse doses. Then I quickly shift over to oral 1 milligram per kg of body weight. Yes.
Oh, so
And
then again you start with the bolus dose of systemic steroids.
yes.
Yeah. Dr. Venkat says thank you. So I think we've partially answered his question. I see Dr. Ritu Arora has joined. Dr. Ajay Arora will not be happy, ma'am. Welcome to a PG class, Dr. Ritu Arora. I can recognize that name. We'll go ahead, Dr. Rupak Roy.
So there are some steroid sparing agents. So so specific therapy against the infective agent with or without corticosteroid started 24 to 48 hours after initiation of anti-infective therapy. So that is another part of his question, that if you are dealing with the infectious cause, first you start the treatment against infections, first start the anti-infective therapy, and after 48 hours you can start the corticosteroids. Steroid sparing agent should be considered when the patient requires chronic oral corticosteroid therapy at doses greater than 10 milligram per day. What are the common immunosuppressives that we have? Cyclosporin, azathioprine, alkylating agents like cyclophosphamide, clorambucil, methotrexate, mycophenolate mofetil, and tacrolimus.
I
And
have
there are
mostly. Sorry, can we go back? Yeah. I have mainly seen the uveitis guys use cyclosporin, azathioprine, and methotrexate. These are the 3 common ones that they use. Uh, Mycophenolate, have you used Dr. Rupak Roy? Actually,
I don't have any personal experience with mycophenolate mofetil.
you have been using what? If you do put them on, what do you normally put them on?
Usually azathioprine.
Is as a therapy. I think most most people before sending to an absolute hardcore uveitis person would start on azathioprine. We are a little comfortable with that. We have more experience with that. And of course, we need to ask once you start on that, you need to ask your patient start doing platelet count, WBC count every 2 weeks, every 1 month, and see what the blood counts also are, because these medications have their own side effects. And I'll just quickly go through again what Dr. Venkat had said. Any patient I am putting on oral steroids, Dr. Rupak and Dr. Pooja, please listen very carefully and please add on if you feel I should add anything else. On my prescription, if I'm looking at a patient of retinal vasculitis, I write fasting blood sugar, hemoglobin TCDC ESR, chest X-ray, MAN2. Sometimes it's a young patient of maybe query EELS disease. I ask for serum, angiotensin converting enzyme. I do ask for a stool for occult blood, a routine urine to look for any infection over there, routine urine and microscopy over there, not for a culture, just a microscopy. Um, I think that's it. Anything else? Rupak, I should we ask routinely. The first battery of investigation itself.
Would also
Chest.
their immunosuppression status. So I would write an HIV also.
HIV, yeah. Yeah, and I was asking a very basic thing. I think I agree with you wholeheartedly. At HIV, the slightest doubt of any, the way I teach myself, the way I teach and I tell all my postgraduates, when the fundus finding does not fit into anything, ask for HIV. A lot of cotton spots, a lot of hemorrhages, a lot of vasculitis, ask for HIV. You have no reason not to ask for an HIV. I agree with Dr. Pooja 100%. Dr. Rupak, you were saying something, sorry?
You have included MAN2, right?
Yes, MAN2, yes.
Oh,
MAN2 chest X-ray, yes.
Yeah, so it pretty well covers the whole gamut.
Yeah. We'll go back to your treatment protocol.
So for PGs, also there are new treatment of vasculitis modalities that have come up. They are the biological agents. the interleukin 2 receptor antibody, daclizumab, TNF alpha inhibitors, infliximab, adalimumab, etanercept, and interferons. So this can anytime come as short notes. So what are the complications of vasculitis? The complications of
Sorry, before we forget, we did not mention some of the people use Ozurdex and dexamethasone implant rarely in cases of chronic uveitis. Dr. Rupak, have you had the opportunity to use Ozurdex in your patients?
I have used Ozurdex in a patient who has a chronic macular edema in a case of vasculitis, yes, when the media is clear. But whenever there is an amount of vitritis due to any uveitic causes, I tend to avoid.
Because you want to know what the diagnosis is, and especially who can't tolerate oral steroids for a long time, a
Yeah.
dexamethasone implant may not be a bad idea. Yeah. So if dexamethasone implant comes as a short note, you can add not only diabetic maculopathy in diabetics in vascular occlusions, also in chronic uveitis, CME due to chronic uveitis, vascularitis. Some of our times we can use Ozurdex implant also. Dr. Astha, can you mute your laptop, please, your microphone? Thank you so much. Thank you. We'll go ahead, Dr. Rupak Roy.
So the complications of vasculitis are macular atrophy or scarring, a capillary dropout which can lead to new vessels, that is proliferative retinopathy and neovascularization, retinal or vitreous hemorrhage, retinal detachment, neovascular glaucoma. So the management of neovascularization, so the management of inflammation is corticosteroids. The management of neovascularization is urgent pan-retinal photocoagulation. But we have to understand, whenever you do pan-retinal photocoagulation in a case of vasculitis, always do the laser after at least 4 to 5 days of steroid intake. That is under steroid cover. Vitrectomy for non-clearing vitreous hemorrhage, tractional retinal detachment, and epiretinal membrane removal, and anti-glaucoma medications if the patient has glaucoma and other entities. So just I'll go briefly through various disease entities. So Behçet's disease is a multi-system inflammatory disease, young adults. So the major criteria is recurrent oral ulcer, skin erythema nodosum, recurrent genital ulcers, uveitis plus retinal vasculitis. Minor criteria is arthritis, epididymitis, GI lesions. HLA-B is involved, HLA-B51 and B5, B51 and B5. Ocular involvement is seen in 70% of patients. Both arterioles, so both veins and arteries are involved. Retinal hemorrhages, cotton wool spots, optic disc edema, hyperemia. Late stages have neovascularization of the retina and optic disc and atrophy. Investigation, FFA will show widespread fern-like leakage from capillary tree and marked vascular sheathing. Another important thing is in Behçet's disease, what Dr. Sinha was initially alluding to, they can have hypopion in the anterior chamber, white hypopion in the anterior chamber. So that is another very important presentation of Behçet's disease. So treatment essentially is again steroids and anti-inflammatory agents. Sarcoidosis is seen mainly in young adults. Plaque-like skin lesions like erythema nodosum, lupus pernio. Lungs had bilateral hilar lymphadenopathy, as you can see in this chest X-ray. Ocular and skin lesions, Bell's palsy, cardiac and conduction abnormalities, childhood arthritis. It mainly involves retinal veins. So there is perivascular cuffings, candle works dripping because of the inflammatory deposits around the veins, mid-peripheral or peripheral in location, retinal infiltrates, sarcoid nodules, snowball vitreous opacities. So investigation would be a skin biopsy, a transbronchial lavage, biopsy of the lacrimal gland, serum ACE, serum lysozyme, serum versus urine calcium. Chest X-ray will show eggshell calcification and HRCT, a ground glass appearance. Gallium-67 scan is also important.
Um,
Treatment.
sorry, Rupa, I'll stop you here. Um, I know most of us would ask for definitely a. Can we go back, please? Can we go back one slide? No, the investigations. Yeah. Most the minimum bit we as ophthalmologists can definitely do is ask for a serum ACE, a chest X-ray, or an HRCT. I think these two or three things to help us send to the patient to correct people. Skin biopsy we can't ask for, we don't ask for, but we definitely get a serum ACE, get a chest X-ray done, and get an HRCT done. Based on this, if you have some doubts clinically, seeing the eye, it's a good reason to send the patient to a chest physician or to a physician and ask their opinion, saying specifically, please look for sarcoidosis, and then they can decide on that. But I think as ophthalmologists, a chest X-ray and an HRCT scan and serum AC can definitely be done. Uh, Dr. Amit, can you please request you mute your microphone, please? Dr. Amit, Dr. Amit, please mute your microphone. Thank you. Yeah, we'll go ahead, Dr. Rupak Roy. Dr. Rupak, please go ahead.
Yeah. So coming to TB vasculitis, it's an immunological response to mycobacteria, increased prevalence among MANTU positive patients, concurrent active.
पेशेंट तो तैयार है लेकिन अभी आया नहीं है सर्जरी का ऑप्थेल्मोलॉजिकल सोसाइटी की तरफ
Concurrent active pulmonary TB is present at times. So what are the findings? Vitritis with vitreous. So basically the findings are same. Vitritis with vitreous novel opacities, retinal hemorrhage. Neuroretinitis is another important manifestation of tubercular vasculitis. Focal or disseminated choroiditis, vitreous hemorrhage, and serous retinal detachment. So diagnosis is therapeutic trial of ATT with improvement of symptoms, MANTU tests, quantiferon gold test, chest X-ray, HRCT, lab culture of chororetinal vitreous samples, smear for HP of chororetinal iris or vitreous samples. Treatment, full course of treatment by a physician, low dose oral steroids after initiation of anti-TB therapy with careful follow-up. Toxoplasmosis is the most common cause of posterior uveitis in immunocompetent hordes, but it can also cause retinal vasculitis. It can either be congenital or acquired. Agent is Toxoplasma gondii. Transmission is congenital or acquired ingestion of undercooked or infected meat. Fundus picture, if you see vitritis, headlight in a fog appearance, is a classical picture that is described for Toxoplasma. Localized, it can give rise to necrotic retinitis. Retinal periphlebotitis, veins show continuous sheathing. Papillitis, focal periarterial exudates or plaques known as Carrel's arteritis, and optic neuritis. Investigation circulating antibodies for IgM, IgG, and IgA. Antibody detected by ELISA, immunofluorescent antibody test, Sabin filament dye test, and Whitmer-Goldman coefficient, and PCR. PCR is the commonest investigative modalities. PCR against Toxoplasma is what we do very commonly nowadays. Treatment is ocular is pyrimethamine with a combination of sulfatazine and prednisolone. Congenital, you give sphingomycin plus oral prednisolone. Also, treatment modalities could be azithromycin and clarithromycin. I'll skip Toxocara because of paucity of time. Now coming to acute retinal necrosis, which is a kind of retinal vasculitis. It is a very important cause of retinal vasculitis and clearly be ruled out as an infectious cause before you directly start on a steroid therapy. It is caused by HSV1 and 2 and varicella zoster virus. Retinal vasculitis begins in the periphery, occlusive vasculitis and papillitis. So it begins in the periphery, starts in a quadrant, then slowly it encompasses and grows around 360 degrees. A full thickness retinal necrosis can ensure. Severe posterior uveitis, thumbprint infiltrates. Vitritis is very common in acute retinal necrosis. Vascular sheathing and sharp demarcation between necrotic and healthy retina. Diagnosis is clinical, also by ELISA against HSV and VZV antibodies, and PCR of DNA from ocular samples, especially the ACTAP. So treatment is
Rupak, 1 second. Can we go back? Sorry. Can we go back to the slide which showed the photograph of ARN? It's very important. Yeah, this one. Now, ARN, the color photo. Yeah. Now, just go slow over here. Dr. Rupak spoke about vascular inflammation, blood vessel sheathing, hemorrhages. Here, the picture is totally different. This, we discussed about vitreous hemorrhage yesterday. I have had patients who had this vitreous haze and were diagnosed, unfortunately, to have vitreous hemorrhage and were sent away without an investigation, just an ultrasound. Retina dash come back in 2 weeks' time. If this patient, God forbid, has acute retinal necrosis, in 2 weeks you lost the game. So again, compared to yesterday's class, any vitreous haze is not always vitreous hemorrhage. You can have a hazy vitreous like this. Disc is barely seen like in the lower photograph. If you try and look at the periphery, you will see this exactly the picture that he has shown. Some whitish grayish mottling in the periphery, gray, some demarcation like the RP Dr. Pranab Das yesterday showed, some demarcation line kind of a thing, very hazy. This is typical of acute retinal necrosis. So the dictum we tell ourselves, if we really can't make out anything at all inside, but it looks yellow, then possibly think of acute retinal ARN. Like a diabetic retinopathy with NVD is a very obvious diagnosis. A diabetic CSME is a very obvious diagnosis. You can see the heart exudates, you can see the microaneurysms, you can see the macular edema. But ARN is never a very obvious diagnosis. It's always this very poor, dull-looking fundus, dull-looking periphery, and then you know it's possibly ARN. Vitritis is quite severe in most of these patients by the time they come to you. And exactly what the fourth point here has shown, sharp demarcation between necrotic and healthy retina, which is why I said yesterday what you saw, the ROP slides, of course, they are two totally different diseases, but in the periphery, the sharp demarcation line of healthy and non-healthy retina is quite severe in these patients. And if you do not treat them very early, same day, next day, these diseases, ARN progresses very quickly. Dr. Rupak, any points on that?
No, I agree fully with you. This is an ocular emergency in which the antiviral therapy has to be started as soon as possible. Start antiviral therapy first, and within 48 hours, start corticosteroids.
Dr. Pooja, anything that you would like to add to this?
So pretty much, I think this is how we follow these cases. And regarding the difference between how will you make out if there is a hemorrhage or if there is vitritis, I'm sure you must have covered it yesterday. Always look at the anterior segment also. Just don't look at the posterior segment. If you see vitreous cells, you know that you have a vitritis at the back and not a vitreous hemorrhage. So this is an important point which can differentiate both the things. And then, of course, the vasculitis and the other features in the retina will give you the diagnosis.
Yeah. Dr. Rupak, we'll take a question over here from Dr. Madhuri. Her question is very specific. What is the most common cause of posterior uveitis, TB or toxoplasma?
TB is the commonest cause.
Yeah. I think there's no more discussion on that. We'll go ahead with that. Thank you.
They will, in your exams, definitely ask you what are the clinical features of toxoplasmosis. It's a very common question and very favorite question with the examiners. So that you should definitely know. That slide which Dr. Rupak showed you was a very important slide. So that you should definitely know. Yes, this one. This one is a very important slide. They ask what are the three things that you see, and you should be able to tell them. And headlight in the fog appearance is what they want from your mouth.
I agree with Pooja. It's a very common question.
So another specific and not a frosted band gingitis is also a kind of vasculitis. It can be caused by various disorders. So it is not a specific disease. It is a clinical finding which can be seen in a lot of disorders. So children or young adults, acute panuveitis with severe vasculitis affecting the whole retina In fact, you will see vascular sheathing along the whole retina. It is mostly idiopathic, but secondary to lot of infections like herpes, rubella, cytomegalovirus, AIDS, toxoplasma, etc. So here you see all the vessels are, there is sheathing around all the vessels. So there is severe vascular sheathing, frosted tree branches appearance, underlying vessels are obscured, there is retinal edema, vitritis and iridocyclitis. Angiography shows dye leakage from sheathed vessels in the late phase of fluorescein angiogram. So diagnosis is by ophthalmoscopy. Fluorescein angiogram can be an important aid. Relevant investigations to find the underlying cause. Treatment is
Dr. Rupak, just 1 second. Approximately how many more slides do you have? Approximately.
I think I should not have more than 4 to 5 slides.
Then can we just go back to that the causes of frosted bronchitis, please?
Huh?
Yeah.
ये सब posterior uveitis है?
Yeah.
नहीं.
Dr. Satyajit, please mute your mic. Yeah. Now, thank you. Out of these, Dr. Pooja and Dr. Rupak Roy, which of these patients have you seen reasonably commonly, once in 2 months, once a month, once in 3 months? These diagnoses that we see over here, I have seen AIDS definitely. I have seen herpes definitely. CMV retinitis I have seen. Rubella, I didn't see frosted bronchitis. It was a small baby years ago that I had seen, and I was actually practicing all this. SLE, I have not seen frosted bronchitis. What about you, Dr. Rupakroy? What patients have you seen?
So frosted bronchitis is a very uncommon uveitic entity. Maybe I don't know. Maybe once in a year you see one case. Even even when I was in Shankar Nethralaya as a tertiary care institute, even in a tertiary care institute like Shankar Nethralaya, you see 1 or 2 cases in a year. So you are right. The common causes that we have seen is herpes, cytomegalovirus infection, AIDS, and toxoplasma.
Pooja, anything you want to add to that?
I've seen most of, I mean, at least 4 or 5 of what Dr. Rupak was mentioning at SN. But in my private practice in the recent past, but I would say cytomegalovirus infections and retinitis, we can encounter if the patient is immunosuppressed, of course, there is a chance to see this.
Dr. Soboshachi, can I request you to please mute your microphone, Dr. Soboshachi? Yeah, thank you. TV can be heard. Thank you so much. Yeah, thank you. We'll move ahead, Dr. Rupak Roy.
So treatment is treatment of the underlying cause, and systemic steroids when treatable causes are excluded. Now finally we come to Eames disease, which is probably the most important cause of retinal vasculitis in our Indian scenario. So it's an idiopathic obliterative vasculopathy usually involving peripheral retina. Patients present with recurrent vitreous hemorrhage can present with retinal detachment, initially unilateral, common among young, apparently healthy adults. There is a male predominance, common in Indian subcontinent and the Middle East. Fundus picture, vascular sheathing of the retinal vessels. Remember, mainly retinal veins are involved. Superficial flame-shaped hemorrhages, mild to moderate vitritis, and cystoid macular edema is very common in this disease.
Dr. Rupa, can we? Yeah. Now, supposing I'm somebody seeing this kind of a patient for the first time, that left eye inferior temporal vessel, can I call this frosted bronchitis?
No, it is not frosted bunch because not all the vasculature. Frosted bunch usually involves throughout the retina. All the vessels are sheathed, but here only one single vessel is. So frosted and angiitis is a severe form of vasculitis. Here it is a focal kind of vasculitis.
So you're telling me in Eels disease, it's mainly males, commonly in males. It may be unilateral or bilateral, but patient usually comes with one eye, the other eye may have much milder symptoms. And what you're telling me is I will have this yellowish around the perivascular area one, finding some hemorrhages, and if it's close to the macula, you might have macular edema also. If the edema has been a long time, then I might find some hard oxidates there also, but it's a long time. So this patient, mild vitritis is usually on the milder side in these patients, is what
Yeah,
you are
mild.
mentioning here. Okay, right. We'll go ahead.
So the two common causes in which a patient with East disease is present to you is the recurrent vision loss, sudden vision loss due to vitreous hemorrhage, or due to a gradual vision loss due to macular edema. So etiology is obscure. There could be some immune-mediated mechanism or enhanced oxidative stress. Association with subjects with MAN2 test, MAN2 positive, which was first probably elucidated by Dr. J. Biswas from Shankanetralaya, Chennai. Vestibular auditory dysfunction, CVA, seizures, and migraine headaches. So these are the staging. This is management of East disease. Corticosteroids remain the mainstay of therapy in the acute perivasculitis stage. Immunosuppressive agents like cyclosporin, methotrexate can be used if there is a need for steroid sparing agent. Anti-tubercular treatment therapy is also indicated if the patient is found to be MAN2 positive with a quantiferin TB gold test positive. And photocoagulation is a very important adjunct in treatment of Eels disease. It helps in preventing the progression to fractional retinal detachment and recurrent vitreous hemorrhage.
Sorry. Can we go back to that slide, Dr. Rupak, please? Can we go back to that slide? Because I think for this group of the audience that we have over here, at least today's take-home message should be an Eels disease. They should be able to diagnose and treat to some extent, at least before sending the retinal surgeon and doing it themselves. So I'll repeat again, a typically youngish patient, 25, 35, 40 is what we usually see. Usually a male, more commonly females also. Usually, like he said, we do not know the etiology of it. It may be immune mediated or could be infective in nature. Most of us nowadays will ask for a serum ACE, a MAN2 test, a chest X-ray, and to confirm the tuberculosis, we do a quantiferon gold test. Most ophthalmologists will never start an ATT on their own. We'll take the help of a physician whom they are already in coordination with, or of a chest physician, somebody who tests these, because you also have to inform and these people and take their help, because once you start rifampicin, it has their own complications. The oral steroids again should be followed up very, very carefully, because if you see those findings of hemorrhage, like Dr. Rupakrao said again, if you have a patient who's coming with recurrent vitreous hemorrhage, that means he already has devascularization. Once the heme settles, he will need photocoagulation. He will also need um, okay, we come to the question. Dr. Madhuri's question, I'll come to that a little later. He will also need definitely evaluation of maybe an angiography if possible. Dr. Ranjit Singh, can we please have Dr. Ranjit Singh? Please mute your microphone, Dr. Ranjit Singh. Dr. Ranjit Singh, please mute your microphone. Thank you. Do it. Yeah. So in the Eels disease, definitely once you have these findings that he showed over here, and one is you're looking at only an inflammation, no neovascularization, then start oral steroids after the basic investigations. If you're finding that, also Dr. Madhuri has asked over here, should we wait for TB report before starting the steroid? Yes, you must wait for, you ask for TB report, dancing, it will get it in 2-3 days time, 4 days time, steroids wait, and then start. Dr. Kavya's question is the dosing of ESD is same, 1 milligram per kg body weight. Yes, the dosing is same, Dr. Kavya. We do not change the dose for ESD disease. What I will say is, and Dr. Pooja, you'll agree with me, otherwise you can contradict me, that if you have diagnosed ESD disease with inflammation, with no neovascularization, and you're starting oral steroids, we would call back a patient, start oral steroids, and call back within 1 week itself to see how much the response is. Dr. Pooja, would you agree with me?
Yes, definitely, sir. Definitely, we have to keep a close follow-up. And the other thing is, if you see a patient with peripheral vasculitis, along with a little bit of vitreous hemorrhage, you have to treat the peripheral vasculitis first. You have to take care of the inflammation first and start the patient on systemic steroids before you go on to treating the hemorrhage in the form of laser or any other thing?
I was going to mention that, so you've already done my job for me. Thank you. So photocoagulation, yes, but under cover of steroids if there is inflammation. Dr. Rupak Rai, anything else we should mention over here at this point, treatment-wise?
No, that is okay.
Okay.
So to conclude, untreated vasculitis can be sight-threatening and even fatal, as it may be the first sign of a lethal systemic disease. Hence, prompt diagnosis and appropriate management of the condition are the cornerstones of management of vasculitis.
Dr. Rupa, I'll stop you. There's a good question from Dr. Akash. Sir, can you do sectoral laser if there is extensive capillary dropout without neovascularization in case we lose follow-up of patients? So I will make it easier for other people who suppose that Dr. Akash is referring to that he has seen a patient with Weil's disease, given oral steroids, starting because there's no infective component, does a basic investigation, does an angiography. And angiography, in one area there is no vasculitis there, but he's seen severe amount of excessive capillary dropout. I would do laser there because that extensive, this is a disease which is not a one-time disease. It may come back again and again. I would do laser there, and I agree with you in case we lose up follow-up of patients. Laser in one corner of the retina will not compromise his vision at all.
Exactly what I would also do, because the extensive capillary dropout will eventually lead to neovascularization. So that will be a sequelae, we all know about it. So it's better that we do the laser and treat the ischemic part.
Yeah. Rupak, there is a question a little unrelated. Dr. Priyanka has asked, Sir, can you please elaborate on difference between retinochoroiditis and chorioretinitis? Before the Rupak answers, I myself am a little bit confused about this, so I will not answer the question. To me, I don't use the word retinochoroiditis at all, but if you have to differentiate and chorioretinitis, reticulochoroiditis, choroiditis is more, chorioretinitis is more, less, more. So I'll ask Rupak Roy to make it easy for me. I don't use these terminologies at all.
Yeah, I think this terminologies used to were common in previous literature, depending on which element of inflammation was more. Whether it is the choroidal part is more, we call it chorioretinitis, and whether it is the retinal part was more, it's called retinochoroiditis. But I think this was mostly in previous literature. Nowadays, this is not used so much.
Yeah, I think that's it. Pooja, you want to add anything else, Dr. Pooja?
I would also agree to that.
Yeah, thank you. We'll move ahead, Dr. Rupak. We'll move ahead.
Yeah, shall I start my second presentation?
Yes, please. Yes, please.
How much
And
time?
I would encourage those half an hour. We can extend also. We can cut short, no problem. Those of you who are online can please keep asking questions. We'll try and answer as many questions as possible.
So we come to clinical approach. I'll go a little faster on this so that I can finish my presentation on time. Clinical approach and examination of pan-uveitis. So basically we have again any uveitis entity involves a history and examination, a cause and diagnosis, and treatment and follow-up. So anterior pan-uveitis is a combination of anterior, intermediate, and posterior uveitis. So pan-uveitis can be differentiated with the use of characteristic ocular features, associated systemic signs and symptoms, supporting investigation findings. So what are the symptoms? Anterior uveitis can have symptoms like pain, redness, photophobia, diminution of vision, lacrimation. Intermediate uveitis can have floaters, blurred vision. Posterior uveitis can have impaired vision, floaters, and metamorphopsia. So differential diagnosis of pan-uveitis with vasculitis like Behçet's, tuberculosis, sarcoidosis, choroiditis, retinitis like TB, viral ARN, Behçet's disease, hypopion, Behçet's disease, infective etiology, With exudative retinal detachment, you are likely thinking of VKH and
You are like
sympathetic ophthalmia. So whenever you see a patient of panuveitis with vasculitis, you think of Behçet's, tuberculosis, sarcoidosis. You see choroiditis, retinitis, you think of TB, viral ARN. You see hypopyon, you think of Behçet's or infective etiology. With exudative retinal detachment, you think of VKH and sympathetic ophthalmia. So panuveitis with vasculitis. You suspect Behçet's disease, you have relatively painless white hypopyon seen in this image. This is a very characteristic sign of Behçet's disease. You find vitritis, severe vasculitis, both arteritis and phlebitis. Varied ocular manifestation of Behçet's can have macular star formation, retinal hemorrhages, disc edema, hemorrhages, and vasculitis. So look for other common features like genital ulcers and extraocular sign like oral aphthous ulcers. So these are two important adjuncts when you are suspecting a case of Behçet's disease. If you see skin lesions like erythema nodosum and pustules, a dermographism, you are also are thinking in lines of adamantid Behçet's disease. So I'll not go into the details of Behçet's disease. If you see a so Behçet's disease is basically a panuveitis with predominantly vasculitis. Now, if you see a case with panuveitis with predominantly retinitis and vasculitis, it is retinal necrosis. If you have characteristic triad of moderate to severe vitritis, severe vasculitis, and peripheral confluent retinal necrosis. So discrete area of peripheral retinitis, confluent areas of peripheral retinitis with sclerotic brothers. Can also present with hypotony, severe vitritis, multiple atrophic retinal tears, sieve-like retina, and can be bilateral ARN also. It can quickly give rise to retinal detachment. Suggestive history could be a prodromal system of viral fever, past history of chickenpox, a herpes zoster vesicle. Confirmation is PCR analysis of aqueous and vitreous samples, rarely retinal biopsy. So ARN was first described by Kurosawa. It is also known as Kurosawa's uveitis. It is caused by herpes simplex, varicella zoster or CMV. Treatment with systemic acyclovir and steroids. Prophylactic laser barrage should be done at the junction of the necrotic and the non-necrotic retina. Surgical treatment is indicated if the patient lands up with retinal detachment. Progressive outer retinal necrosis is another entity where there is minimal ocular intraocular inflammation in immunocompromised patient. Several multifocal deep dense retinal necrotic lesions, mostly in the posterior pole, then extends throughout the retina, and poor proptosis with RD and optic atrophy. So this is another variant of ARN, which is a PORN, progressive outer retinal necrosis. Remember, also necrotizing herpetic retinopathies. Diagnosis is mainly clinical, atypical presentations in immunocompetent, and PCR is very helpful in diagnosis. PCR tells you it is whether it's a herpes simplex virus or it's a varicella zoster virus. So now we have covered panuveitis with vasculitis, panuveitis with vasculitis with retinitis, which is ARN. Now we come to panuveitis with exudative retinal detachment. So the common causes are Vogt-Koyanagi-Harada's disease, sympathetic ophthalmia, MFC with panuveitis syndrome. So the commonest causes are basically VKH and sympathetic ophthalmia. You have to find out whether the disease is unilateral or bilateral, whether there is any history of trauma, associated choroiditis, whether it is recurrent or not. Bilateral exudative RD in a patient goes with a granulomatous reaction in the anterior chamber, goes towards a Harada's disease. FFA shows multiple pinpoint leakages, which has to be differentiated from a multifocal CSR, which will have larger ink blot like leakages. In VKH, you have multiple pinpoint leakages. In CSR, you have multiple blot like leakages. Because at times CSR can also present with like an exudative retinal detachment, though the inflammation part will be absent in cases of CSR. Ultrasound will show choroidal retinochoroidal thickening. The normal retinochoroidal thickening should be less than 1.2. If it is more than 1.2, you know you are suspecting a choroidal thickness. OCT shows multiple neurosensory detachment in patients with VKH. Also ask for headache, tinnitus, vertigo, meningismal sign, prodromal symptoms of a viral illness. So, so the Vought Kainagi-Harada disease typically has a prodromal stage, an acute uveitic stage, a convalescent stage, and a chronic recurrent stage. Treatment is with a systemic steroid plus immunosuppressants from the beginning. So remember, in VKH, reactivation usually anterior uveitis. ICG is also helpful to diagnose posterior segment involvement, and IVTA is a useful option in cases of a recurrent inflammation.
Dr. Amit Chaudhar, can we please ask you to mute your mic, please? Dr. Amit Chaudhar.
On the contrary, suspect sympathetic ophthalmia if you have a granulomatous reaction as subretinal fluid at the posterior pole and a history of penetrating injury. So symptoms of SO are mild visual disturbance. Specifically, patient complain of near vision compromise when the disease is starting. They say their near vision have become blurred due to change in accommodation, pain, redness, and slowly it progresses to significant visual loss. Bilateral granulomatous panuveitis that occurs after either surgery or penetrating trauma to one eye. Traumatized eye is called the exciting eye, and the non-injured eye is called the sympathizing eye. So time from injury to onset, anytime between 1 week to 66 years it can happen. So etiopathogenesis is aberrant immune response. Management is prompt wound closure and early enucleation of the injured eye. Aggressive immunosuppressive and steroids after onset. So this VKH and sympathetic ophthalmia are diseases. In previous retinal vasculitis, we have discussed that always start treatment with anti-inflammatory agent, that is corticosteroid. If it is not getting controlled, then you move on to immunosuppressive agents. But diseases like sympathetic ophthalmia and VKH need a combination of immunosuppressive and steroid from the onset. So here the selective approach won't work. You should not start only with steroids. You start both together, steroids and immunosuppressives.
Dr. Rupak, just hold on. We have a question here from Dr. Julia Magno. Sir, how can we differentiate from VKH from bilateral CACR based on clinical findings? So I'll repeat again, VKH and CACR on clinically, how can we differentiate? Some hints that you can give to us, please.
That is a very good question, and this is a common diagnostic dilemma. So VKH is a pan-uveitis. So it will have some sort of features of inflammation like SC cells, anterior vitreous cells. Whether CSR is a non-inflammatory disorder. So here there will be we don't expect any inflammatory cells. So this is one very key differentiating point. Whenever you see anterior segment in a case of VKH, you can find cells. In CSR, cells are very unlikely. Second, the disc will be hyperemic in VKH. In CSR, the disc is usually not involved. Third, in both CSR and VKH, there is collection of fluid in the retina. But in VKH, the fluid collection is usually multifocal pockets of fluid. In CSR, though multifocal pockets of fluid is possible, but it is not very common. So I would say these are the common differentiating features which helps and clinically to diagnose between CSR and VKH.
One, again, a small hint, possibly in some cases of bilateral CSCR, CSCR is sometimes a recurrent disease. So you can also have this RPE alterations, the inverted flask type image, some smaller RPE changes over there. These are more common in bilateral CSCR because CSCR would have happened multiple times. Usually, very rarely, you will have a patient who will come first visit bilateral CSCR. They will have some history of having had earlier some loss of vision got better, or some mostly done 6 years back. So those are another few small hints. Clinically, you can see sometimes inverted class type of RPE changes, and some RPE mottling changes also can be seen in CSAR, which is usually not common in VKH. Anything else, Dr. Pooja, VKH and CSR?
I was just wanting to make this point that it is very important to differentiate between these two conditions because the treatment is totally different. If you confuse between CSCR and VKH based on clinical findings, you may end up giving steroids in case of CSCR and then it will worsen. So it's very important to make sure what you're dealing with and then start treating.
I'll put one more question, one more statement here. I have had patients where we've misdiagnosed, we have mismanaged a patient, which is why, again, what Rupak said earlier, VKH, CSR, you did clinically, you thought something, you did some DFA, again, you thought something wrong, and then you started, let's say you started oral steroids, thinking it is VKH, which is why now this follow-up is very important. Like Dr. Pooja also said, call in 3 days time, call in 5 days time. If it starts responding, then you are correct VKH. If it worsens horribly, you know you made a big mistake, you misdiagnosed, and it's probably a CSAR. The CSAR multifocal both eyes will worsen very quickly with oral steroids, with high dose oral steroids. The VKH may not respond so much so early, but the CSR will worsen horribly within 5 to 7 days. Am I correct, Dr. Rupak?
Yes, and
Yeah,
then
correct.
what Dr. Rupak said was very important. On FFA, you will definitely have a hot disc in VKH, which you will not have in CSCR. So if there is disc involvement, then you definitely are dealing with VKH and not CSCR.
Yeah.
So this is a slide where you can see a case of CSCR where SRF is usually seen in pockets in posterior pole, rarely ocular pain and no inflammatory signs, and there will be multiple ink blot leakages. Now we have to understand this is a ink blot leakage and which is entirely different from a pinpoint leakage which is seen in VKH. So by angiography also you can differentiate between a CSR and a VKH. In a VKH, you will have pinpoint leakages. In CSR, you will have ink blot leakages. And another important modality is to differentiate is ICGA, indocyanine grid angiography. Indocyanine grid angiography, if you do in a case of CSR, you will find hyperpermeability or hypercyanescence or mid-phase hyperpermeability. On the contrary, in a case of VKH, you will see hypospots. So this is also helps in clinching in your diagnosis if you have really that kind of dilemma. So remember, bilateral granulomatous panuveitis with exudative RD is VKH. History of ocular trauma suspect with a granulomatous panuveitis with exudative RD is the SO. Commonest presentation of VKH can be asymmetrical. Unilateral VKH should be differentiated from posterior scleritis and CSR.
Posterior scleritis, I'll just make a quick point over here. One of the very typical of posterior scleritis patient has severe pain. This is one where the antiuveitis patients, iritis, iridocyclitis, they have pain. But posterior they will say severe pain. The amount of difficulty the patient has is they will not let you touch the eye. The moment you touch that, they will jump. So this is posterior scleritis. This is a very, very important. And posterioritis, sometimes you will see some little findings. You may not see little congested eye. You may not have too many findings in posterioritis. You do an ultrasound. You might have a T sign. You might not have some total thickening posterior pole. Some fluid may be there. But the moment you start oral steroids, 2 days later, they're absolutely 1 second dose. Their pain decreases fantastically. So posterior scleritis, one main thing is severe pain, and pain on tenderness is one thing. Anything else to add, Dr. Rupak?
No, I think that this is what very important. Pain is the main, and T sign on ultrasound. So we are going ahead with panuveitis associated with systemic disease. If it is a granulomatous uveitis, you think of tuberculosis, sarcoidosis. Others, you think of syphilis and Hansen's. Suspect TB panuveitis if mantle positive, chest X-ray, CT scan positive, quantiferon test positive, intraocular fluid and PCR should be done, and other evidence of systemic diseases. Suspect sarcoid panuveitis if you have skip lesions of vasculitis, candleworks drippings, and snowballs. And also you can have other clinical features like erythema nodosum and lupus pernio, which are skin lesions. So it is sarcoid if the mantle is negative, chest X-ray, HRCT goes for hilar lymphadenopathy, raised serum ACE, bronchoalveolar lavage, gallium scan, and histopathology. Syphilis mimics many conditions, varied manifestation, RPR and TPHA is confirmatory. ARA-associated panuveitis, presence of arthritis, chronic and peripheral, below 16 years of age, at least 6 weeks of duration when other causes have been excluded. Pauci-articular, polyarticular, or systemic onset. Other causes could be a lens-induced uveitis, which is a granulomatous total hypermature cataract and a phacoanaphylactic cause. A post-traumatic uveitis with a history of trauma and inflammatory reaction occurs in the same eye, other eye uninvolved, and a uveal effusion syndrome. Other conditions mimicking panuveitis could be an endogenous ophthalmitis, which can be seen in extremes of ages, evidence of systemic immunosuppression or infection, acute onset, and another very uncommon entity but not very rare is a large cell lymphoma, present in elderly patient, predominantly presents with posterior uveitis and mimics viral retinitis. So panuveitis, previous trauma, uh, can trauma can give rise to sympathetic ophthalmia, lens-induced uveitis, traumatic uveitis, and uveal effusion.